Righty. Well, good morning to everybody, and thank you for joining early on a Monday morning. I um, I was asked to sort of pinch it today, but I thought I would try to do something that hopefully will be of some interest to people, um, and talk a little bit about some interesting cases that I have learned about that have taught me along the way in terms of neonatal neurology, which is a long-standing passion of mine. So it's usually done best as an interactive discussion, and it's always really very hard on Zoom. But what I would suggest is if you've got a pen and paper, keep it next to you. We've got 5 cases, and be interested to see who can score 5 out of 5 on this. So I have no disclosures or conflict of interest, but I do want to acknowledge two of my mentors that I was extremely fortunate to have trained under 2 really iconic child neurologists, one in London, Victor Dubowitz, who really instilled in me a passion for not just neuromuscular disease, but the scientific inquiry process. And while working with him, I had a wonderful exposure to his wife, Lily Dubowitz, who, as many of you might know, is really he unfortunately passed away recently, preeminent neonatal, not a neurologist, but was a neonatologist. And then I did my training under Joe Volpe, who is truly one of the most remarkable people I've ever met. And he, again, inspired in me an inquisitiveness. And it was Joe Volpe in writing when asked, what has he learned in terms of his career? He made the point that it's sort of an interesting history because he really was the first sort of official neonatal neurologist in that sort of title, training under Victor Adams Ray Adams. And Phil Dodge, and it was Phil Dodge at WashU that sort of said to him that this was an area that needed to be explored and needed to be done. And it was really only in the 80s that this field really expanded, although he started working in this area in the late 60s into the 70s. But the explosion of information has been nothing short of remarkable. And perhaps the single biggest lesson he taught me more than anything is that when you look at the newborn, you examine the newborn, most of it is done by careful observation, and that you can pick up incredible clues by just watching and observing the children or the babies. And that's what I want to get at a little bit today. Another colleague of mine from Cleveland, Mark Scher, a pediatric neurologist, but had a strong interest in fetal neurology, particularly in the placental environment, also used to make the comment that really the fetal neonatal neurology is certainly a science of uncertainty. So despite 40 plus years of growth development within neonatal neurology, a lot of the principles and practices behind what we do are still just being worked out. And to quote Charcot, the famous French neurologist, in the last analysis, we really see only what we are ready to see, what we've been taught to see, and we eliminate, ignore everything else that is not part of our prejudices. And I think particularly in neonatal neurology, the thing that I've learned more than anything is to really keep an open mind and not fall down those pits and those traps of just pigeonholing things. So this is the first case. William Osler famously said the value of experience is not in seeing much, but in seeing wisely. And this was a case, not the first one I came across. This was more recently. So I'm going to show a video just for a few seconds. And I would ask people, and of course, it's not going to play now. There we go. So you go to the bedside to see this newborn baby. As you can see, it's a premature baby. And is having these multifocal myoclonic jerks. Initially, it looks a little bit rhythmic in both upper extremities, but if you look very carefully down towards the leg, you'll see some asynchrony in the leg going. Obviously on a ventilator, and obviously is being EEG monitored. And then the nurse calls because she's concerned about seizures. So when you come to the bedside and you see this, what would be the sort of thoughts, the differential that would go through your mind? I would also point out that just prior to the onset of this, something took place, and we'll discuss that in a second. But when you see newborn babies, especially the premature babies with these abnormal movements, it sometimes can be really very, very difficult to know what it is that we're dealing with. Just because we're on Zoom in the interest of time, I won't ask people specifically what would be in their differential diagnosis, but consider it for a minute and think about what would be highest on your differential. So when we look at neonatal or infantile myoclonus, there's quite a large differential to this. Certainly, we do see some of the myoclonic epilepsies emerge during the neonatal period, and these can be divided into the either benign course, which the kids do really very, very well, or unfortunately, some of these progressive myoclonic epilepsies like Baltic myoclonus, not Milas-Burf, excuse me, and Leforabody and all these sorts of things. Obviously, we do see the benign neonatal and sleep myoclonus. As kids fall asleep, they will have a hypnagogic jerk and wake themselves up. Hyperexplexia. Myoclonic tics would be kind of unusual to see in the neonatal period. Certainly, maybe towards the end of the first year of life, you may think about it. And similarly, opsoclonus myoclonus syndrome. I'm not sure I've truly seen it in a newborn, but I have seen it in very young children, a couple of months of age. And then you could also look or think about segmental myoclonus from a spinal cord lesion, as well as other things. So when looking at this baby, bear in mind that this is a premature baby. And as I mentioned, something was done just prior to the baby having the onset of these movements. And this is a very, very well described entity when you've seen it. But this was a case when I first saw it, I hadn't known about it, I hadn't recognized it. Now that I've seen it, it's very obvious, and you often don't really need much more of a workup for this. And this is midazolam-induced myoclonus. Baby on a ventilator, they were going to do some suctioning to the baby, was given a dose of midazolam intravenously, and very shortly thereafter started with these multifocal myoclonic movements. Completely benign. There's no reason to have to stop the midazolam, although most people tend to get a little bit scared of this and will stop it. But as you can see, the EEG is completely normal. There's no signs of this being epileptic in any way. And so the question then became, well, why would this happen, and why particularly in the premature baby? And so this is an important concept that I think is probably familiar to many of us, that early on, especially during fetal development, the fetal brain and the neonatal brain is incredibly excitatory, and that's why they have a lot of these adventitious movements. They're constantly jerking and twitching and doing all sorts of things that make life really difficult to try and discriminate. And early on in development, the glutamate receptors, the excitatory receptors, actually predominate. And GABA, which later in life is really an inhibitory receptor, as we all know, actually early on, the GABA receptors are in fact depolarizing, non-inhibitory, and so in fact are excitatory. And this gets to the work of Greg Holmes and others who have at least hypothesized and shown in animal models that potentially the use of things like benzodiazepines in a premature or early neonatal brain may, and I say may, have potentially toxic effects, even though we know that when these babies have seizures, we still use the benzodiazepines and they seem to work. It's hard to know at exactly what point this crossover in the light blue here of the inhibitory GABA from the the depolarizing GABA from the inhibitory GABA take place, but it certainly takes place over the first few weeks, if not the first few months of life. The other thing that is important just to bear in mind, again, perhaps more on a theoretical basis than what we see in reality, is that at least in vitro, it has shown that early GABA activity, the depolarizing excitatory components, is very important for trophic functions, which include cellular proliferation, dendritic growth, neuronal migration, etc. And so there's at least a theoretical concern about using GABA in the premature babies, although in practice in life, we really still continue to use it. And the postnatal GABA shift is really the last major shift that takes place in these GABA receptors. So, for me, that was an incredibly important lesson. One, because once you've seen it once, you kind of can recognize that you know the right questions to ask. And once you've seen it, you don't have to overtreat it and you don't excessively treat it, because we know that the correlation between EEG and neonatal seizures is often not very good. People will often overtreat this, but really, if you really want to stop it, you just hold the Versed or the midazolam, but there's really not a reason to have to do so. So the second case, again, was, this has probably been one of the most fascinating cases I've had during my career. And again, to quote Osler, the diagnosis of MIS not because of a lack of knowledge on the part of the examiner, but rather because of a lack of examination. And I would sort of paraphrase it a bit. Sometimes when we see things on examination we can't quite explain, we sort of just leave it out of our equation or now figuring into what's going on. And that was the case with this newborn. I was asked to see this baby born at term gestation. There was some fetal distress, but it really wasn't too bad. It required a cesarean section. The APGARs in the end were 8 and 9. And she developed clinical clonic focal seizures on day 2 of life, right arm twitches. And the thing that was most fascinating to me, this isn't the newborn picture of her, this is a little bit later on, but you can see shining a light in her eye. There's absolutely no constriction of that pupil. So she had essentially a non-reactive pupil, and this was present at birth. And I wasn't really sure what to make of it. I just kept thinking, well, it's probably just me and not really examining her the way that I should be able to examine her. So I sort of dismissed it to a large extent. Head circumference was normal. She had no dysmorphic features. But interestingly, because of some difficulty with ongoing respiratory issues, some feeding issues, she got an MRI at 10 days of age. And when you look at the MRI, these are T1 images, you can see within the white matter these bright T1 signals throughout extensively actually throughout the white matter. And the radiologist, called this HIE, hypoxic ischemic encephalopathy. Although there was a little bit of distress at birth, there was nothing that quite fitted that picture. And yes, she had a dependency on a ventilator, but she really didn't have any hemodynamic instability as such. So it was a little bit unusual to see this, but in the absence of other explanations, she was diagnosed with HIE, both as a diagnosis as well as pathophysiology. And then slowly what was unusual is on day 3 of life, she really went into congestive heart failure. And what you see here, here's your ascending aorta. This is the pulmonary artery. And as you know, there's the patent ductus arteriosus that is in utero and really typically closes shortly after birth. But this was a little bit more of an unusual ductus in that they call it an aortic pulmonary window. So essentially the aorta and the pulmonary artery were almost directly anastomosed to one another through this very, very large aortic pulmonary window. And so the surgeons had to go in and ligate this, which was really the cause of her heart failure. And they did that at 6 weeks, and she actually was able to come off the ventilator at that point. However, I continued to see her in outpatients, and over the next 7 years, she really developed cerebral palsy, and quite a significant cerebral palsy. She had an asymmetric spastic quadripresis. She had cognitive delays. She was microcephalic. Interestingly, had a little bit more sparing of her left arm, so it was this asymmetric pattern, but for reasons that were unclear. And so over the course of time, I did repeat the imaging of her, and at 7 years, again, going back to the 10 days of age, a T1, and then obviously shifting to a T2 here. But again, you see this extensive periventricular white matter abnormalities. But when you see her at 7 years, you can see how extensive this white matter abnormality had become, with sort of cystic breakdown within the white matter, almost heading towards a leukodystrophy sort of appearance and pattern, but yet she really didn't have a degenerative course or aggressive course in any way. So it always bothered me. Her whole history didn't really fit. This was not, even though she was diagnosed as HIE, this really didn't fit an HIE pattern. Typically for a term baby, this is also not the pattern you would expect for HIE. They typically will get cortical. It's usually selective neuronal necrosis, unlike the premature babies, which do get the periventricular leukomalacia or the PVL. So this was a term baby. You would have expected more selective neuronal necrosis with involvement of the basal ganglia, the the motor strip, the motor cortex, the pyramidal cells of the motor cortex, temporal cortex, temporal horns, as well as the cerebellum. But in the absence of anything else, she was diagnosed with, spastic quadriplegic cerebral palsy secondary to HIE. I never used the term birth asphyxia because that didn't really fit with her pattern. But as we know, many causes of HIE is due to an antenatal onset. But this whole picture and the worsening of this white matter really bothered me. She did have, and I won't go through it all, quite an extensive workup for other etiologies, and everything returned negative. I was not able to find anything. So again, I would ask any thoughts as to what this diagnosis may be. And then what happened next was one of the things that I found most remarkable in medicine, and it's a really good learning experience known as serendipity. And based on an experience which I'll elucidate in a minute, I got an MRA to look at it. And this was the MRA. And this MRA is really pathognomonic for this diagnosis. It was read by the neuroradiologist as moyamoya disease. You see the stenosis of the distal ICAs into the proximal M1s, but there was flow distal to it. But there was something on this that, again, didn't feel right, looked very different from typical moyamoya, and I'll come back to that. So again, I would ask, does this help you in terms of your diagnosis? So taking one step back, about just over a decade ago, Deanna Milowicz, who was in Texas, published this paper known as, where she described a de novo ACTA2 mutation in infants and in children that causes this multisystemic smooth muscle dysfunction. And this was quite an extensive and quite a severe disorder. Now, ACTA2 gene mutations you may recognize, because this is really the one of the strongest causes of familial thoracic aortic aneurysms, which we typically see in young adults or older adults. But this was a very different phenotype that she picked up and noted in Rigaldo's lab with ACTA2 mutations. And so again, as chance would have it, Deanna Milowicz was visiting Cleveland Clinic at the time. There was a genetic meeting going on, and there was a table of people, including the geneticists I'd been working with for this particular kid who was sitting next to Diana at the time. And it was just shortly after she published this paper, and she sort of described some of the features of what these children had. I think it might have even been just prior to the paper coming out. So Rosie Moran said to her, told her about this case we had and said, would you be willing to sequence the ACTA2 gene that wasn't commercially available at that point? And sure enough, this patient of mine ended up having this ACTA2 gene mutation. So ACTA2 gene mutations are probably a little more common than we realize because it often does get misdiagnosed as HIE. It often gets misdiagnosed as moyamoya. And again, the history is such that it's easy to attribute it to it unless you pick up on a couple of these unusual issues. As far as the imaging, what's really striking in terms of the ACTA gene stuff is you really don't get the moyamoya vessels, which are the lenticular striate proliferation of vessels because of the stenosis at the distal ICA or proximal M1. So you can see here, there really isn't that proliferation. The second thing that's really striking, and I think it's obvious here even more so, is you get this aneurysmal dilatation of the distal ICAs, and that you don't see in moyamoya. So the ICA generally is pretty normal, whereas you get this proximal dilatation of the internal carotid artery. And then the third feature is if you look at the normal orientation of the vessels of the M1s and A1 vessels, this comes off much more vertically. And almost every kid well, not almost, in every kid I've seen with ACTA2, this is really very telling and quite striking. So you don't get the leptomeningeals, you don't get this posterior persistent communicating artery that you see in moyamoya. So just the imaging alone should really give you the diagnosis in these children. But again, it's one of these things, if you don't think about it, or if you've not seen it before, it's really hard to make the diagnosis. Now, shortly after that, we published a case, which was this young girl having this R179H mutation, which is a specific mutation in the ACTA2 gene that differs from the mutation seen with the familial thoracic aortic aneurysms. And again, it just speaks to the power of how when you have these unusual cases, it's really worth putting it out into the literature. It was one of the first detailed cases about the neonatal presentation, as well as the sort of leukoencephalopathy appearance in the sort of HIE mimic that we put out there. And the reason I highlight this is this young boy called Zeke. And Zeke came to see me from Tennessee. And this is Zeke and his dad, and I have the permissions to show the pictures and not to mask the faces. He's given me permission for that. But what was really interesting about Zeke was when he was born, he had to undergo repair of a really, really large PDA, which, as you can imagine now, turned out to be a aortic pulmonary window. One of the things that is unique to this R179H mutation is there's incredible vessel friability, and the surgeons going in, whether it's the cardiac surgeons or the neurosurgeons, need to know this because these vessels crumble and fall apart, and you've got to be very, very careful when you anastomose the vessels. Unfortunately, they didn't know it at the time, and he ended up suffering a spinal cord stroke when they went in to repair his PDA, an incredibly rare complication, but it didn't really trigger any bells for them. I eventually get a call from his pediatrician because Zeke got admitted to the ICU at his local hospital. And as you can see through these series of diffusion imaging, he had been admitted. And at this point, he was obviously paraparetic, but he had very good functional use of his arms. He was a very active kid. And because of these progressive strokes he was having on an almost daily basis, they did not know what to do with him. They couldn't find any obvious etiology for it. And to the credit of his pediatrician, he had been doing some literature search, came across the article we had written about this 7-year-old girl that I just presented, and he contacted me to ask whether I thought this might in fact be an ACTA2 mutation. He sent me some of the images, told me the history, and I said I really did think it was. And so they asked if they could transfer the kid to us, which they did. And one of the rare occasions went in acutely to reanastomose him, and he did unbelievably well. But just to show you what had again been missed, and this is just a normal T1 scan, oh sorry, these are flares, scans, just as what a scan had looked like. And again, nobody had really paid attention to it other than saying, well, he must have just had some chronic ischemic changes, around the time that he had his spinal cord stroke and his cardiopulmonary surgery. But again, if you looked at his MRA at the time, again, had been called moya-moya, but had this classic aneurysmal dilatation, these vertically orientated vessels, this distal tapering and narrowing of the ICA. So we did acute not we, but the neurosurgeon did acute reanastomosis of him, and he had almost complete recovery of those diffusion defects, did not result in any further permanent deficits to him, and he really did remarkably well. And it was really a telling story for me about how important it is when you have these unusual cases to be able to publish them so that people are aware of it, because that's what gets people to think about things that they might not otherwise think about. And this particular ACTA2 gene mutation is not the typical one that you see in the adolescents and adults. It occurs with very early onset in the neonatal period, and it has a very, very high penetrance of vascular disease. And as I mentioned, the vessels are highly, highly abnormal. And going in, you've got to be aware of this. Otherwise, we really can result in disasters occurring. Almost the consistent features associated with this phenotype is you get that ascending aortic aneurysm, you get ascending aortic aneurysms as well as aneurysms of the distal ICAs. You get these aortic pulmonary windows, which I've elucidated already. You certainly get quite extensive cerebral vascular disease, which mimics moya-moya, but really is not moya-moya. And then here's the kicker. These children, because of the smooth muscle involvement of the iris, have a congenital mydriasis or a fixed dilated pupil. And again, something that I had noted, but I had dismissed because it didn't really fit into my paradigm of what was going on with her. It's something that always bothered me. And Zeke had the exact same thing, by the way. Other things that are common but don't all get is a general sense of hypotonia, which includes the bladder, malrotations, pulmonary hypertension, and prudent belly, interestingly enough. If you look at the neurological problems, again, not a common disorder, although I do suspect it's a lot more common than we realize just because people don't always test for it. But almost universal is this white matter signal abnormality that we see, and then very high incidence of the so-called intracranial stenosis, moya-moya-like picture. Stroke is very, very common, as is seizures as well. And then if you look at the eye abnormalities in these children with the 179 mutations, again, most, if not all of them, are going to have the congenital mydriasis, because some people refer to it as an aniridia, but my ophthalmology colleagues tell me it's not truly aniridia for reasons I don't really understand, but they refer to it as a congenital mydriasis, but you do get a little bit of retinal involvement as well with it. So turning to the third case, again, sort of labeled "A picture is worth 1,000 words." And this was another really important lesson for me. And I got involved in this in a somewhat unusual way. This is because, again, this is a case back from Cleveland Clinic. There was a litigation going on against our ICU there and against the obstetricians about this baby that I'll talk about. Well, what they do there is a lot of internal review first. They find somebody familiar with the particular issue at stake, and they ask us to review the cases, give an opinion on the cases, and then they sort of move forward on the basis of that. So I was asked to look at this case, and actually subsequently this patient did become a patient of mine as well. And, Steve Jobs famously said, learn continually. There's always one more thing to learn. And I'll add to that there's always smarter people than you. And I've certainly realized that throughout my career, that there's a lot more intelligent people than I am. And relying on their help is a benefit, not a hindrance. So again, this was a term female, really uneventful pregnancy, labor, delivery, and she presented on day 5 of life. I think she went home day 2 or 3, if I remember correctly, but really an unremarkable postnatal course, NICU course. But she came in with recurrent apneas, for which neurology was consulted, in a newborn baby as to whether these were seizures. The baby had fevers and irritability, multifocal seizures, that we subsequently became much more obvious apart from the apneas, but no real hemodynamic instability. And that's sort of important when I sort of was reviewing the chart. She actually subsequently went on and had one of the worst cases of refractory status for a newborn that I've seen in quite some time, and really required an escalation of medication without much benefit. She had an extensive sepsis workup. Everything came back negative, particularly obviously the herpes PCR and intravirus PCR, both in blood, urine, and CSF. But she had quite significantly elevated inflammatory markers. So she had a sepsis-looking picture, but everything in the CSF looked fine. And over the years, eventually following her, she really ended up with quite significant cerebral palsy and quite moderate to severe delay. And this was her MRI at the time that she came in, day 5 or day 7 of life or thereabout. And as you can see, this is the diffusion scan with very extensive diffusion abnormality in the periventricular white matter, and you can see already T2 shine through. This was on the same date as the admission. This is not her case, but this is exactly the same presentation that she had. This is from the literature, but they are absolutely identical cases. And as I'll illustrate, that these cases do tend to present pretty stereotypically. And so once again, it was diagnosed as HIE. It was said that the apneas, when she was monitored, did not show seizures. They said that this kid was misdiagnosed because those apneas were seizures. She slipped into a status epilepticus that wasn't recognized. They also said because of the respiratory distress at birth that the neonatologist had missed that this kid had had some birth asphyxia. And so this pattern, they had expert opinion saying how classic this was for HIE. Again, I would just make the point that in a term baby, this is not a picture of HIE. As already mentioned, with term babies with HIE, the classic issue at that point, because you have a maturation of the oligodendrocytes, is that you get selective neuronal necrosis. So you have, again, the pyramidal cells, the CA3 layers, the pyramidal cells, you have the temporal lobes affected, you have the basal ganglia affected. All of that was spared in this kid. So again, the question is the diagnosis. Any thoughts as to what this might represent? And once again, it takes one to learn about it, but once you've seen it, it should always be in your differential. You should always think about it. The reason this was important for me was I knew this didn't fit HIE, but I could not figure it out. And so after doing a literature search, I came across something, and then I approached my mentor, Joe Volpe, who generally did not do medico-legal work. And because I knew that he was so interested in the neonatal stuff in his textbook that he's written, I said, wouldn't he please look at this? And he actually eventually agreed to be an expert witness and confirmed the diagnosis. So this is something called human par echovirus. And what is interesting, until relatively recently, well, maybe 15 years ago, the par echoviruses were originally classified as enteroviruses. The problem is they are distinct enough that if you do an enterovirus PCR, which had been done on this child, it comes back negative because there are distinct differences between them, and you will not pick it up on a specific enterovirus PCR. Human par echovirus is a very well-established neurotrophic virus, and it results in the severe neonatal encephalitis. What's unusual about it, what's distinct about it, is there is frequency and absence of any inflammatory markers in the CSF. And you won't find cellular changes, you won't find protein, no glucose, you won't find the infection unless you do the PCR for it. And what's interesting is most children will have acquired picovirus passively by 5 years of age, but it's a very small percentage, for reasons we don't know, that end up with the severe neonatal encephalitis picture. And again, it's the serotype 3 that has particularly been associated with the neonatal infections, CNS infections, that you need to be aware of. But again, remember, you have to do a PCR specifically for human picovirus to look for this. So the imaging features are somewhat unique, not absolutely pathognomonic, but when you see this pattern, as I just showed you, and I think I have another slide of no, I don't, but if I just go back to it real quick, this pattern of extensive periventricular white matter abnormality, in particular, where it crosses the corpus callosum. You see this with H-flu encephalitis in older children, but in the neonates, when you see this, again, think about the human par echoviruses. And again, you've got to differentiate it from HIE, certainly from many metabolic conditions. But the whole path of this, the severe seizures, for example, are quite specific to this condition. And it's very different, again, from HSV encephalitis, where you really end up, especially in the neonate, it's not really confined to the temporal lobes like it is in younger children. It's really very extensive gray and white matter disease. It's quite encephaloclastic for a newborn, one of the most devastating encephalitides we see with HSV in the newborn baby, but it's much more destructive globally, including gray matter. So moving on, the next case is again one of these situations where, when you sort of initially see it, it's sort of cute and wonder about, is it of any significance? And until you really know what it is, although I'm sure everybody on this call has probably seen it, you don't realize what you're missing. And the old adage of what I don't know can't hurt me. I sort of was always interested where that came from, and so in looking it up, it actually comes from a play or a novel written by George Petit back in the mid 1600s, who said, "So long as I know it not, it hurteth me not." But unfortunately, sometimes putting your head in the sand can be a little bit dangerous. I'm just going to have a quick look at the chat here. I'm not sure if these are questions or not. So Gary Morris was just saying Craig Press in Colorado and Chop unofficially called the NMR pattern for the park of the chicken foot sign because of the anterior T2. Yeah, that's a good analogy. Anyway, so this baby I was asked to see bedside because of an abnormal facial appearance. When you first see the baby, didn't look very dysmorphic, didn't look unusual in any way. Again, born at term, a pretty unremarkable course. Postnatal course was unremarkable, good APGAR scores of 9 and 10, didn't require any resuscitation, didn't require any instrumentation of any sort. But then you sort of take a look at this baby and you start to see a concern with this baby. Again, I'm sure this is familiar to most people as to what this diagnosis is and what the differential for this diagnosis should be. And so the question is, well, so what? And so the first question is the diagnosis, and give people a second to think about it. But if you look at this baby, things that are quite striking on this baby, and generally what gets missed is we generally are going to get consulted here because of a facial palsy, particularly of the left side, because of the drooping of the mouth on the left side. But the actual pathology here is on the right side. And the pathology is that this part of the mouth is not drooping. So when the baby cries, this part of the lip should come down. And this is an entity that I'm sure you're aware of, known as asymmetric crying facies, described a long, long time ago in the 1960s by Penry and Hoppenagel. And it's really due to a congenital absence or hyperplasia of a tiny muscle at the corner of the lip called the angularis oris muscle. And this muscle is innervated by the ramus marginalis mandibular nerve. And it's thought that this is where the problem lies for reasons that are not entirely clear about it. But I think what's underappreciated and not recognized, because it's mostly dismissed, is that anywhere from about a half to 3/4 of these children can have other anomalies. And some of these anomalies are quite significant, and you really don't want to miss them. For reasons that are, again, unclear, even though the baby I just showed you was right-sided, left-sided predominance occurs in about 80% of cases, but it's not known why this happens. And it's really quite common, occurring in anywhere up to 1% of all newborns, which is quite a significant incidence of this condition. But here's the problem. There's a condition known as Kehler cardiofacial syndrome, which is really asymmetric crying faces associated with congenital heart disease. And this was initially recognized by Kehler, for who the syndrome is now named, in '69. And almost half of these children are going to have heart disease, and often quite significant. And in fact, many of these kids turn out to have a 22q microdeletion that we see with the so-called velocardiofacial to George sort of spectrum disorder. But also remember that there's about 10% of these babies that can have quite significant brain anomaly associations with it, including things like microcephaly, cognitive or mental impairments, as well as cerebral atrophy. And just to compare it to another baby here that does have a classic facial palsy, again, you can see the lip going down on both sides. The difference here, as you see on the side where the lip is being depressed, you see closure of the eyes. On the other side, you see, because of the facial weakness, this eye does not close. You can perhaps appreciate a little forehead wrinkling, which you don't see on this side, whereas here it's really pretty symmetric, very deep symmetric nasolabial grooves. Here, this nasolabial groove is much deeper than you see on this side. So this is a congenital facial palsy, and this is the situation of asymmetric crying facies. This baby fortunately didn't have other associated features. And then just recently, which is why I love doing the fetal neurology, was this case that just came to light, who was detected in utero and actually confirmed after birth as having an asymmetric crying facies, again, in this case, on the left side here, and really quite striking. Hopefully people can appreciate the two eyes, the nose, the top lip, and the bottom lip here, with depression on this side, but failure to depress on this side. This is just a forearm and fingers and hand going in there. So I actually got through that a little quicker. I do have one more case, so I'll quickly run to that since we have a bit of time. And again, this is another condition that at the time I was unaware of the neonatal presentation of, and I'm sure there's a lot more smart people online here that have probably seen this and will recognize it. But again, Louis Pasteur basically said all things are hidden, obscure, and debatable if the cause of the phenomena be unknown, but everything is clear if this cause be known. So one of these situations, once you've learned about it, once you know about it, it's one of the things you for sure don't want to miss a second time. So this was a term baby delivered by normal vaginal delivery, again, unremarkable pregnancy, negative maternal screens. pretty much unremarkable pregnancy, no use of any illicit drugs, alcohol, medications of any sort, normal ultrasounds, and then uneventful labor and delivery. But again, on day 2 of life, you're called to examine the baby because of this erythematous and vesicular rash. Now, this was the first case I had was many years ago, so I don't have pictures of that baby. So I've taken this from an encyclopedia, the Dermat Atlas, which is a great website if you're ever looking for neurocutaneous type issues. But this was sort of very similar to the rash that I had seen. And certainly for me with dermatology, it's not a strong point. And I sort of looked at this baby, thought, okay, well, see vesicles, you always have to worry about herpes. Did the herpes exclusion rule out? Everything came back negative. Sort of thought maybe it's just, a baby rash of sorts. The one interesting thing is when you took off the diaper for the baby, and again, this is from the same baby previously, not the one I looked after, but had the exact same pattern. What you might start to recognize here are these lines of Blaschko, where you see these vesicular papules running along these lines of Blaschko. And that's sort of more unusual than the typical sort of baby rashes that we see. So again, thoughts about this? Anybody know what this is? I'll show you a picture of what this becomes, and I have no doubt seeing this picture, everybody knows what it is, but it's in the newborn babies that I hadn't seen it before. So this is what it's eventually going to become with these hyperpigmented, in this case now it's become a macule, the papular rash has disappeared, again following these classic lines of Blaschko, and this is incontinentia pigmenta, which I'm sure is familiar to everybody on this call. So incontinentia pigmenta is an X-linked dominant neurocutaneous disorder. It affects the skin, but again, presents in the newborn period. You can get alopecia, hypodontia, microdontia, and abnormal shapes. So again, things we don't often think about looking at, but the teeth and the nails are really important to look at for these babies. But these kids often end up with cognitive impairment, seizures, and cerebral palsy, and it's due to what used to be called the NEMO gene, but now known as the BKG gene, which is X-linked. And right now, it's the only gene associated with IP, although it only accounts for about 80% of cases. So there are probably other, whether it's regulatory genes or other genes that we have not yet identified. And the skin lesions go through these characteristic 4 stages. You get that bullous stage, which is usually in the early neonatal infantile period. These blister-like bullous eruptions, they tend to be linear on the extremity, but they can again be circumferential, like you saw in that older child with IP. It then gets through this verrucous stage where they start to become crusted and then eventually hyperpigmented. But again, they still tend to be pustules for the most part. And then it ends up in the classic stage I think we're all familiar with, which is these whorls of brown macular hyperpigmentation along the Blaschko's lines. And again, they typically are circumferential around the trunk, but you also see them in these sort of linear streaks along the extremities. And ultimately, over many years, it undergoes atrophic changes. And so you lose the pigmentation and they actually become hypopigmented and they become hairless, but involving the same area. And you may actually start to see the alopecia, scalp involvement emerge at that time. So the question is, well, what does it matter? Well, it's because of this early diagnosis that's important, because what happens is you get neovascularization of the retina, and this can occur very, very early. That can lead to retinal ischemia, eventually retinal detachment and blindness. So like with tuberous sclerosis and the glaucoma story in the newborn, it's not as much obviously the skin marks or the seizures that may or may not come, or the CP that may or may not come, but it's the ocular manifestations of newborns that we have to be aware of that puts them at risk. And so, again, you've got to look for retinal detachment if you're noticing that the baby doesn't seem to be seeing right, having trouble grabbing, reaching for objects, if they develop a strabismus, or if they start to develop a torticollis. And so they need regular ophthalmology, much like we do for tuberous sclerosis, starting in the first year of life. And it occurs in about 50% of these patients. And here's just a fluorescein angiogram highlighting these sort of anomalous vessels that you get with it. And again, just a regular fundal picture here showing the same thing. So I thought that would take a little longer, but it does leave 15 minutes. So if anybody has questions, comments, lessons that they've learned, I'd certainly be more than happy to hear from you. Let's see, is there a comment there maybe? All right, well, we don't need to belabor it. Thank you all for joining. Give you back a few minutes in your day and appreciate you joining so early.
Thank you very much. That was wonderful. I do have one question, Neil, or just kind of a comment on that. On the patient with the par-echovirus infection, you know, I have heard of it. I haven't seen it myself. In terms of the CSF having absolutely no features at all, when you call it meningitis and the CSF is negative, how do we reconcile
it's truly an
completely?
encephalitis. It's not truly a meningitis. So when you look at the brain pathology on these children, again, it's really confined to sort of pretty much gliosis, axonal destruction, things like that.
Right.
So that's why there
nothing we
isn't any
find down low.
meningeal irritation, which is probably why you don't see the cellular elements too. But it's just curious that despite this overwhelming sort of sepsis picture they get, including the CNS, you know, again, a significant number, if not perhaps the majority, but certainly a significant number have completely bland CNS. And so that's why it's really important to send. Unfortunately, these days, we have incredibly comprehensive viral panels we can send, but often just because of a limitation, we will, of CSF, we sometimes really target the common ones, which is HSV and the echoviruses, but just remembering that you will miss it with by just screening selectively for those PCRs.
Much appreciated.
Sure. All right.
I only got 2 right, so I don't know about anybody else.
Yeah, I should have asked if anyone had all 5. Probably give a reward. All right. Well, thanks everyone for joining. Appreciate it.